All right, Dr. Holick, good afternoon. If you could just start off by telling us about your new exciting research paper and kind of the feedback that you've received so far from that paper, that would be great.
Well, it's a pleasure to be here, and I've been over the past 40 years seeing patients in my clinic, children and adults, with a variety of metabolic disorders of calcium, vitamin D, and bone metabolism, including collagen disorders. And over the past 40 years, probably have seen more than 1,500 patients with Ehlers-Danlos syndrome. And it's well known in the literature that adults who come in with a fragility fracture, one of the possibilities is that they have a genetic disorder, either osteogenesis imperfecta, brittle bone disease, or Ehlers-Danlos syndrome. And so over the past decade, I've now seen a multitude of infants who have presented with various fractures in various stages of healing. And when I evaluate the parents, I often find that at least one of the parents, and possibly both of the parents, have classic evidence for Ehlers-Danlos syndrome. And it's usually hypermobility type 3. And this disorder, you make as a clinical diagnosis what's known as the Beighton score, so that you go through a variety of maneuvers. And patients with EDS have a lot of different clinical problems as well. And so once I make the diagnosis in a parent, I'll then see the infant. And if I see that the infant has some classic signs for this genetic disorder, like blue sclerosis, for example, or the parents are telling me that, they pick up their child and the joints click all the time, or they're like little Houdinis because they can get out of restraints easily. It's very classic for joint hypermobility. And even though it's more difficult to deal with infants in terms of them being submissive to these multiple maneuvers, if you're really quiet and gentle with them, you can really get a feel for their joints, and you can feel whether or not they have some increased elasticity. And I will often see whether or not you can have very significant rotation of legs, hypermobility of the shoulders and of the fingers and of the wrist. And so of these more than 100 families that have come to me who had been accused of child abuse, I started to look at extenuating circumstances and potential other causes. And one of them, of course, on my radar screen was Ehlers-Danlos syndrome. And when I began to realize is that this bone fragility associated with adults, you would automatically assume people would have accepted it for infants. Nobody had ever published this. So we decided to look at all of the cases that we had, and we have 72 cases of infants that presented with fractures in multiple stages of healing and were diagnosed as due to non-accidental trauma, which of course is a euphemistic term for parents abusing their children. And we reported in dermatoendocrinology this year those 72 cases that we carefully documented. What we found remarkably was that of these 72 cases, 93% had a parent, or when I was permitted to see the child, had evidence for Ehlers-Danlos syndrome. And the other 7% was classic vitamin D deficiency rickets. So we identified in infants unequivocally that fragility fractures are associated with both Ehlers-Danlos syndrome as well as vitamin D deficiency rickets. And the hope had been that now we have a published paper in a well-respected peer-reviewed journal, and that the scientific community would embrace that information. And I think that it's going to take a while for them to do so, and hopefully others will be making similar observations and publishing as well to confirm our observations, because it has enormous implications for families globally who innocently will bring in their infant because of upper respiratory tract infection or felt a pop in the arm, only to be arrested and being accused of child abuse and having their children taken away from them. So it's been received quite well, especially by many of the experts in the bone field.
Thank you so much, Dr. Holick. We have a few questions from our members of our Fracture Family Closed group. One is, what advice do you have for women during a second pregnancy who've already had a child diagnosed with EDS due to fractures in infancy? What advice would you give them for their second pregnancy?
Right. So the first is, it would be really good to demonstrate that either the father or the mother has EDS, because EDS independently can have some significant complications during the pregnancy. So that pregnancy history should be looked at carefully, and if there was premature pregnancy or other issues during that the first pregnancy, then that obstetrician should be very much aware of the fact that mom or dad had EDS, and that if mom has EDS, to be particularly concerned about her going through her pregnancy because of all of the complications that can occur. We urge all pregnant women, minimum should be on 2,000 units of vitamin D a day with adequate calcium supplementation. Often, moms with EDS often have difficult time in eating anyway, and during pregnancy can really have severe emesis, lots of nausea and vomiting. And so one of the first things that they'll eliminate from taking will be a prenatal vitamin or their vitamin D. And we would urge them to, in fact, make sure they are. A very nice study done by Dr. Hollis and Wagner in South Carolina showed that pregnant women taking 4,000 units a day, which is what I recommend as well, will maintain healthy blood levels, not only for the mom, but also for the developing fetus.
Does that increase with multiple birth, like a twin or
Multiple
gestation pregnancy?
Right, and so we don't have any evidence for that,
Okay.
And the reason is that even though the infant is the developing fetus is using some of that vitamin D, as long as the mother's blood level is sufficient, she's providing both or even three, if they're triplets, enough vitamin D.
What is your opinion on what is considered sufficient vitamin D level for the mother and also for an infant?
Yeah, so I was fortunate enough to chair the Endocrine Society's Practice Guidelines Committee. This is a society of physicians of over 18,000 doctors who specialize in a variety of hormone-related issues, endocrine-related issues, including bone. And I put together a panel, all experts in the field of vitamin D for infants, children, young adults, middle-aged adults, and older adults. We looked at all the literature, and we concluded that to guarantee vitamin D sufficiency, just for bone health, that your blood level of 25-hydroxy vitamin D should be at least 30 nanograms per ml. However, there's a variety of assays out there, and you can't really know for sure how good they are. So to guarantee sufficiency, we said a preferred range of 40 to 60 is a good place to be, but up to 100 is perfectly safe. The Institute of Medicine, whose goal was not to treat and prevent vitamin D deficiency in people at risk, but rather for the population at large, concluded that you only needed 20 nanograms per ml. But the Endocrine Society looked at their analysis and concluded that some of what they had analyzed, we felt, wasn't completely accurate. And there's all the more reason why I think most doctors worldwide do accept that cutoff of 30 nanograms per ml as the minimum. And for those that are, for example, in Europe or down in South America, that 30 nanograms per ml is equivalent to 75 nanomoles per liter for those that may be using that nomenclature.
And what steps would you recommend be taken to get the American Academy of Pediatrics on board to mandate vitamin D testing at birth for a mother or newborn? Or do you think that's even something that can be accomplished?
Right. So the Endocrine Society does not recommend screening. I don't recommend screening at all, because what you should be doing is all pregnant women should be taking 4,000 units of vitamin D a day. So therefore, they're automatically going to be sufficient. and that all infants from the time they're born require minimum 400 units of vitamin D a day. That's what is recommended as standard of care from the American Academy of Pediatrics. The Pediatric Society in Canada recommends some infants up to 800 units a day. And the Endocrine Society recommends infants 400 to 600 units a day. So there's no need to have to go through the blood drawing, especially for an infant, which can sometimes be difficult. It can be expensive. Third-party payers may not want to pay it. You could wind up with a $200 bill, right? There's no need for this. But if there's extenuating circumstance, right, then it's a different story. So if you have a mom, for example, that has serious GI issues and she can't absorb vitamin D, that most definitely she needs to be tested. But under normal circumstances, it's not cost effective. We should simply be increasing our vitamin D intake.
Okay. And then do you have any recommendations on how we, or as a community, or people that are advocating for families like ours, how do we go about to educate more doctors regarding why vitamin D is so important, why Ehlers-Danlos syndrome is not rare, and how these type of fractures are occurring and people are being falsely accused? Do you have recommendations for what we can do as a group, as a whole, to educate more doctors when we're not doctors ourselves?
I think that's a really good question. I mean, I think the first step was obviously to have a paper published documenting this, and we've now done that. And so no longer can anyone say, well, it's theoretically possible, but there's no evidence for it. I think that we do have clear evidence that Ehlers-Danlos syndrome, which causes bone fragility fractures in older children and adults, that infants are at extremely high risk. So many of these infants that are presenting with, say, 22 fractures of the rib cage, it's likely that they were fracturing their ribs during birthing. And that you never knew it because the infant's crying, probably crying in pain, not realizing that actually some of these ribs are being fractured, right? And just normal handling with a very fragile skeleton does the same thing. Because vitamin D plays such a critical role in helping you accrue more calcium, if you're vitamin D deficient and have EDS, you're in serious trouble, because you're at much higher risk of fracture. Because what often doctors don't appreciate is that vitamin D deficiency not only prevents you from putting calcium into your bones, but at the same time, vitamin D is taking calcium out of your bones and putting it into your bloodstream to keep all neuromuscular function and most metabolic activities in check. So what to do? I think what we need to do is start really a very fundamental level of even in school, because there's a lot of children that have EDS and they have all these crazy symptoms, right? They get up quickly and they feel lightheaded, or they're playing soccer and they may have had an ankle sprain, right? And often they're always written off by their pediatrician as being clumsy, or that they have dyspepsia because they're constantly throwing up because they can't eat. I mean, I think that we really need to make parents well aware of this, because it's not a rare genetic disorder. It's estimated probably 1 in 5,000 have this genetic disorder. It's autosomal dominant, which means that that child had a 50% chance of acquiring it. And if both parents have it, that child has a 75% chance of acquiring it. I think that in medical schools, this needs to be taught more, because again, EDS basically affects all organ systems. And so as a result, whether it be dermatology or gastroenterology or cardiology or rheumatology, many of the associated symptoms with EDS are due to this genetic disorder that they will see and often don't really connect all the dots. And then finally, I think that what you're doing is great. I think that getting on a website, I think that social media can make a very big difference.
One other quick question, just to tie into, you were talking about calcium. There are so many different types of calcium on the market. I have my personal opinion about what I think is better, but I don't know if it's accurate. I mean, do you have a particular type of calcium that you recommend that people take?
Absolutely.
Which kind is that?
Dairy. is by far the best. And so, in my opinion, contrary to popular belief, because there's a lot of stuff on the internet saying that, especially for adults, that they should not be taking dairy, in my opinion, it's the opposite. I mean, they've shown now in teenage girls, if they get their calcium from dairy, it's better for their skeleton than it is by taking a calcium supplement. I always tell my patients that, look, you're getting a source of whey protein. It's one of the best sources of protein. It has all the essential amino acids, right? And this concept that's out there about alkalinizing your body if you're on a plant-based diet, turns out that the only animal source of protein that doesn't cause acidification of your body is dairy. So we think that dairy alkalinizes the body, provides whey protein, gives you an excellent source of calcium that does not cause cardiovascular calcification. And so I recommend to all of my patients, unless they have a lactase deficiency, that drink milk. So I have all of my young patients, infants and children, on milk. I personally drink 3 glasses of milk every day. And I've switched most of my patients to dairy, and it works very well.
So for the lactose intolerant, truly intolerant patients, what type of what type of calcium supplementation? Because there's calcium citric malate, there's calcium carbonate, is there a certain type that you recommend?
Right. So first I recommend lactate milk, if you could tolerate it, because it's a little bit sweeter. And often a lot of patients do. Many patients with lactase deficiency are able to tolerate yogurt. And so 8 ounces of yogurt is the same thing as drinking 8 ounces of milk. So often what I'll have patients do is switch a little bit, right? Also, orange juice is fortified with calcium. It's the most bioavailable source of calcium. And so I often recommend to all my physician friends when I give presentations, a simple way to increase your calcium intake, switch your orange juice in the morning to what it says on the label, calcium fortified orange juice. Regarding all the other calciums, so the concept out there had been that if you're on, say, a medication that prevents stomach acid from forming, right, that you can't use calcium carbonate, like Caltrate, for example. And so a study was done back in 1987, published in the New England Journal of Medicine by Dr. Recker. And what they showed was that patients that have no stomach acid, if you swallow a piece of chalk, it doesn't dissolve. But if you take that piece of chalk and take it with your meal, as your food is being ground up, so is the piece of chalk. Because you're absorbing calcium in your small intestine, it doesn't need stomach acid to absorb it. However, the other issue is kidney stones, right? So most kidney stones contain calcium. So many docs think that you should, or patients think, you should stop taking all calcium. It turns out that population studies have shown if you increase your calcium intake, you reduce your risk for kidney stones. And the reason is that the major cause of kidney stones is hyperabsorption of oxalate, which is in dark green leafy vegetables. And so if you take calcium with your meal, say lots of milk or even your calcium supplement, the calcium binds the oxalate in your gut irreversibly and prevents you from absorbing it, reducing risk for kidney stones. But for my kidney stone patients, instead of putting them on calcium carbonate, I'll put them on calcium citrate. The problem with calcium citrate is that most of the calcium is citrate, and that's why those pills are a lot bigger. And so if you read the label carefully, to get 1,000 milligrams, you actually have to take 2 twice a day. And a lot of my patients, especially older patients, don't like swallowing a lot of pills. So again, much easier if you can tolerate milk or orange juice containing calcium or eating a yogurt. It's a much better way.
I just wanted to ask about, just getting back to, I think it relates with the calcium a bit, but can you talk a little bit about bone density testing with children and infants?
Right.
Because there seems to be a lot of controversy as to how reliable they are.
Right. So there's 3 issues. The first is you assume something, which is that if you have fragility fractures, that you must have low bone density. Turns out not to be true. I have many patients, young women, like 19, 20, 21 years old, that are like on our cross-country team, for example, that present to me with stress fractures. They have EDS, right? And they have normal bone density. And the reason is that, just as we had discussed before, is that EDS is the same thing as building a bridge instead of with steel rebar, with plastic rebar, so that you have that flexibility. In most places don't have a standard for what a bone density should be in an infant or child. Also, that child is rapidly accruing bone density, so at any one day, it could be, it's on the rise. So it's very difficult to make any sense out of it. And so I don't recommend that infants and children have a bone density because it doesn't really give you any insight. Okay, and but for adults it's a different story, and because you're looking for osteoporosis, and if you do have EDS and low bone density, then you're probably at much higher risk of fracture.
Do you know of any evidence that supports that women who are on magnesium sulfate, particularly usually during their pregnancy, either for seizure prophylaxis during preeclampsia or for preterm labor, if being on magnesium sulfate, which my understanding from my own personal practice for what I do for my job is that normally women are on it for maybe about 48 hours. Does being on magnesium sulfate in a hospital setting and the high dosage, does that affect the stability of a joint or that's what I'm trying to say, like bone density? Can that cause susceptibility for fractures just that short period of time?
No.
Okay. That was one of our questions.
I do have one. Yep. So for me personally, during our case, I wished that there was a paper like the one that you just published, that kind of proved what we were saying in court, in medical literature. But I know that you are a researcher, so if you had unlimited funds and unlimited time and unlimited access to patients, what research do you believe would make the biggest impact in this false allegations of child abuse for EDS and vitamin D deficient rickets today?
Sure. So I think the most important thing is that there is no genetic test for EDS3, and often the experts will say you can't make a diagnosis of EDS in an infant, that they have to be at least 3 to 5 years of age. I don't believe that, and I think that I've shown over and over again that you can, but that's still the mindset of the medical community. So we need a genetic test. So our first goal is to obtain as many families as we can and collect their DNA, and then to do genetic analysis and to see which genes are involved. And then if we find there's a cassette of genes that's very common in all of these patients that we diagnose with EDS clinically, then we can develop a genetic test for it. And by doing so, then even if you have a 4-week-old infant, you could do a blood test and make that diagnosis. And that hopefully would help in preventing a lot of this from happening.
Another question that we have from one of our members is wanting to know, there's a study that's recently been published or current research going on. It's called the Massey University study in New Zealand. It's in regards to increased prevalence of vitamin D deficiency with children and infants that are thought to be on the autistic spectrum, and also the same question in relation to children showing global developmental delay. Do you know of any link regarding vitamin D deficiency and autism or?
So there's a study that was done in Australia by Dr. McGrath's group, and what he did was he made female rats vitamin D deficient, and then they became pregnant. And then he took their pups and he looked at their brains compared to the rats that were vitamin D sufficient. So we have a group that's deficient giving birth and a group that's sufficient giving birth. And they looked at the brains, and the brains were bigger in the rat pups that were vitamin D deficient. Why? Because there was much more white matter than gray matter. There's evidence that if an infant is born at the end of the winter in Australia or up in Scandinavian countries, they have a much higher risk of developing schizophrenia later in life. We know that there's a lot of association with vitamin D deficiency and increased risk for Alzheimer's disease, depression, neurocognitive dysfunction. Part of the issue with autism is that it's estimated that 1 in 600 children may have autism. And we find that everybody's vitamin D deficient. And so it's sometimes hard to make that very careful, clear link. But there's no question that autistic children are less likely to be outside. A major source of your vitamin D is sunlight. And so as a result, they are at much higher risk of vitamin D deficiency. And yes, they should all be getting vitamin D. But all infants and children should be getting vitamin D supplementation. But like I said, you have a vitamin D receptor in your brain. Your brain definitely responds to vitamin D. And so autism may in some way be associated, and you may even see some improvement potentially if you were to correct that vitamin D deficiency.
On the same note of kind of what you were saying about everyone being deficient, what would you say to, I don't want to say the critics, but the people that are out there that say, well, everyone's vitamin D deficiency, has the vitamin D deficiency, so what's the big deal? Like, you're going to take your test and you're going to be deficient. Like, what do you say to people that have that kind of attitude?
Right.
As though it's something that you just should just look over because everyone has it.
Right. So just on NBC last night, they had a vitamin D story, and that's exactly the kind of concept that they came across, that there's lots of information out there, but we don't really know if vitamin D really reduces risk of cancer and heart disease and autoimmune diseases. But there's over 40,000 publications now making a lot of these links. Every tissue and cell in your body has a vitamin D receptor. We just found 291 genes that we could up and down regulate just by giving healthy adults 2,000 units of vitamin D a day for 3 months. So we think that vitamin D is critically important. One insight, I think, into understanding how important sun and the vitamin D connection is that they've done studies in Maasai herders, because they're probably like our hunter-gatherers, right? Forefathers, thousands of years ago, outside every day. Their blood levels are around 40 to 50 nanograms per ml. That's equivalent to taking 4,000 to 6,000 units a day. We also know that human breast milk contains no vitamin D. Now, this makes no sense that Mother Nature would not have had women have vitamin D in their breast milk to satisfy their infant's requirement. Except our hunter-gatherers outside every day were making thousands of units of vitamin D a day. And Dr. Holick has shown that if you give lactating women 6,400 units of vitamin D a day, finally puts enough vitamin D in their milk. So that's what we think our hunter-gatherers were making, and that's what we think we all need. And even though there's a lot of naysayers out there, my argument is simple, and that is there's no downside to increasing your vitamin D intake, and that the amount of money it costs to get a supplement is really inconsequential. We think that you could reduce healthcare costs across the board by 25% just by improving everyone's vitamin D status. And that the fact that you're vitamin D deficient, you can't easily feel it. Okay, sometimes you can in the wintertime, aches and pains in your bones and muscles, but usually you don't. We think that vitamin D is a sentinel for good health, and if you don't have it around, you definitely are more likely to develop chronic illnesses throughout your life.
So for the general person in the population that is concerned about vitamin D or wants to improve their vitamin D status or address that this might be an issue for them, what do you recommend? Do you recommend I'm just going to go buy some vitamin D and take it, or should they see their physician and get a level checked, or what is appropriate and what is safe?
Right. So we don't recommend screening, right? I've said this before, okay? And that to follow at the minimum endocrine practice guidelines, right? Because we're recommending prevention and treatment of vitamin D deficiency, and most we think are vitamin D deficient. So infants, 400 to 1,000 units a day up to 1 year of age. Children, 600 to 1,000 units a day. And I think teenagers should be like adults. So, and the recommendation is 1,500 to 2,000 units a day. But if you're obese, a BMI of greater than 30, the vitamin D gets diluted in your body fat. So you actually need 2 to 3 times more. So I have all of my patients on 3,000 unit equivalent. So I tell children should be on 1,000 units of vitamin D a day, and teenagers and adults, minimum of 2,000, and preferably 3,000 to 4,000 units a day, because that's what our hunter-gatherers were always making and generating. That's how much I take. So what about sunlight? So time of day, season, latitude, degree of skin pigmentation. So working with the group out in California, Ontometrics, we developed an app. It's free on your Android and on your iPhone. It's called dminder.info, so dminder.info. It will tell you anywhere on this planet, any time of the year, if you can make vitamin D, how much vitamin D you're making, and it warns you to get out of the sun so you don't get a sunburn.
Very nice.
So I have a question from the live audience right now. So could you explain first the danger of antacids, especially during pregnancy, and what is a safe alternative?
Right, so there's this concept out there which is not completely correct, which is that if you take Tums during your pregnancy, that you're putting your infant at higher risk for developing rickets, right? That, in my opinion, is incorrect. If you're taking an amount of Tums that's equivalent to about 1,000 to 1,200 milligrams of calcium a day, right? But excessive amounts of calcium carbonate can definitely cause some abnormalities in calcium and bone metabolism, both for the mom as well as for the infant. So typically, I'm not at all concerned. And what I like about Tums is A, it's cheap, and B, it's a good source of calcium, right? Because as soon as you chew it, it's automatically bioavailable. So you don't have to worry about the stomach acid issue or anything else. And often pregnant women don't like swallowing things, right? And so Tums can be a good source of calcium. My preference still is milk, right? But Tums is okay. I have many pregnant patients taking Tums, and I feel very comfortable with them doing so. Just don't do it in excess.
For someone that has Ehlers-Danlos syndrome, and do you feel like the recommendations for vitamin D need to be increased more than the average population as far as like how much they should be taking daily?
Yeah, it's a good question. And I'm always asked the question, so what about elderly, for example? And the answer is no. It turns out that everyone needs the same amount, because you're not going to correct the disorder in the collagen matrix that's associated with EDS, right? And people somehow think, and I see my patients doing this all the time, is that they've been calcium and vitamin D deficient for most of their life. Now all of a sudden they've realized they have osteoporosis, so now they take 3 times more calcium. It's not a wise thing to do. We still recommend 1,000 to 1,200 milligrams of calcium a day. There's 300 milligrams in 8 ounces of skim milk or skim yogurt, which is a great source. And that you don't need to increase it. You will not overcome the EDS issue, right? You won't make those bones any stronger by taking 1,000 versus 3,000. But if you're taking 3,000 milligrams of calcium, you're going to increase your risk for kidney stones. If you take too much vitamin D, you could wind up being toxic. But how much do you need to be toxic? A lot. You would have to take like hundreds of thousands of units a day for probably a year or two to worry about it. We did a study in healthy adults, and we showed 10,000 units a day was perfectly safe. And a very nice study done in Canada by the Pure North group showed that some Canadians were taking up to 20,000 units a day. And we published the data and showed that their level was around 60 to 80 nanograms per ml. None of them were even above that 100, which we say you have to begin to be concerned about.
What are the signs of toxicity?
Yeah, it's a good question. And so it's subtle initially because your blood calcium goes up. So you can become constipated, right? You can have a little bit of depression or a little bit of cloudiness in the head, but those are really nonspecific. But what now happens is that you begin to calcify your kidneys, and you can get kidney failure. You calcify your blood vessels. And so when you become vitamin D toxic for a long period of time, it stays around for a long period of time, and it can ultimately cause death.
So I have another question from the live audience. What is the probability of an infant being born vitamin D deficient if the mother is vitamin D deficient at the time of birth?
Right. So the answer is 100%, because the infant totally depends on mom. But the more important question is, if you're taking a prenatal vitamin, which hopefully you're doing, right, which contains vitamin D, is it going to be enough to prevent you from becoming vitamin D deficient? And the answer is no. We did a study here and showed in 40 mother-infant pairs, and we followed these mothers carefully. So they were drinking milk, 2 glasses a day on average, taking a prenatal vitamin, right? They were getting 600 units of vitamin D a day. 76% of moms, 81% of newborns were vitamin D deficient based on the IOM recommendation of less than 20 nanograms per ml. So a prenatal vitamin will not prevent you from being vitamin D deficient throughout your pregnancy, and more importantly, your infant will be born vitamin D deficient, likely having some infantile rickets.
We have another question from our viewers that want to know, why are so many other medical professionals determined to disprove your research?
I think part of the problem has been that nobody had ever thought about this. Nobody had ever connected the dots, realizing that Ehlers-Danlos syndrome is associated with bone fragility in adults. So it's not a stretch to think that an infant that has hardly any bone mineral to begin with and now has this fragility of their skeleton is going to be at much higher risk. Hopefully the publication that we now have just come out with will begin to kind of infiltrate into the medical community, to beginning to think about this, to make physicians aware of this issue.
Can I put it in a simple word, just to, in my head, this makes
Yes.
sense? So earlier in the broadcast, in case other people weren't listening or in on the broadcast, you mentioned, you have a child who's like Houdini, who can get in and out of a car seat, for instance. My twins used to be able to, at very young weeks old, be able to get themselves, their arms out of the car seat straps. So you have severe vitamin D deficient premature twins with these dislocating joints. So the dislocating joints, the weak bones, those sort of manipulations to themselves, that's creating fractures in their body in a sense, because they're able to dislocate and move and compress themselves, and that alone in a sense could cause those fractures.
No question about it.
So I think that's where the thought process is like, well, EDS doesn't cause fractures, but it's EDS with this severe vitamin D deficiency rickets and these hypermobile kids who get into these twisty Houdini-like maneuvers. That's where, in my situation, I feel it had happened.
Right. But it turns out that I've had a lot of cases where the mom was actually taking enough vitamin D,
Right.
but still had exactly the same problem.
Right.
And then something that we haven't talked about is that there also is capillary fragility and easy bruising.
Yes, that's true.
And so often I've testified in cases where they would also say, oh, by the way, that when an infant was brought in, that they had these marks on their chest that was obviously due to some kind of compression to the chest. What it turned out was likely the straps that were holding the infant tightly because the infant was so effective in trying to get out of the restraints.
I have another question from our viewers. Can you be a stiff EDS? Could you have the hypermobility type of EDS but not score high on a Beighton score, but have all of the other kind of comorbidity issues with EDS?
Yep. So I've seen, like I said, over 1,500 patients now, and I certainly see patients like this. Plus, what often isn't appreciated is that if you continue to sublux your joints, keep popping them in and out, you wind up losing that Teflon coating, basically the articular cartilage. So often patients wind up with osteoarthritic type of problems, so that they no longer can do the Beighton score, but they may have been able to do it when they were children. And then the other issue, of course, that I see often is that, especially when patients are overweight, they no longer can bend over and touch the floor with the palm of their hands.
We have another question for you. I want to know, why are doctors so quick to say infantile rickets doesn't exist in the United States?
Because they've been taught that rickets looks like a child that has bowed legs, for example, that only occurs when the child is beginning to walk, because it's gravity pushing down on the body, and with the very minimum mineralization of the legs is that it causes a bowing out or a caving in. But you only can make the diagnosis of infantile rickets based on x-rays, and only by an expert radiologist who's familiar with this. One of the earliest clinical signs, believe it or not, for vitamin D deficiency in an infant that a family doctor would ask a new mom 100 years ago was, does your infant have profuse head sweating at night? It's a classic sign for vitamin D deficiency. And so often in my evaluation, that's certainly one of the questions that I ask, and it's kind of a tip-off that something's going on.
So on an x-ray, what would be, I know this is a little bit further out of your scope of practice because you're an endocrinologist, but I'm sure you have some understanding of what would you see on an x-ray of an infant or a child who has rickets? Like what would be a typical thing that you would see?
Sure. So I've seen lots and lots of x-rays with children with rickets, and in fact published a paper in 2006 in the Journal of Clinical Investigations, one of the most prestigious journals, and they wanted somebody to write about rickets in children, and they asked me to write that review. So for example, you'll see what's called a frayed growth plate. It's not really very well formed, is one of the classic signs. You could also have widening of the growth plate is another classic sign. You can see hypertrophy of the costochondral junctions, right where the ribs are coming together. It's called a rachitic rosary. Yeah. And so these are just some of the classic signs. Also, it turns out that in an infant who is not walking yet, just the tug of the muscles on the arm can sometimes cause a bowing of the arm. So there are lots of very subtle and not so subtle physical findings and x-ray findings. And the classic one, which of course is also they consider classic for child abuse, is the so-called CML, or classic metaphyseal lesion, right?
Also known as a corner fracture or
right.
back handle fracture.
And it turns out that radiolucency is also a classic sign for vitamin D deficiency, infantile rickets.
So we're going to allow 2 more questions.
Okay.
The first is, do people with vitamin D deficiency have more problems maintaining normal magnesium levels? Are the 2 related?
No.
Well, very good. So the second question is, would knocked knees be another symptom instead of bowed legs?
So absolutely, like I said, so either they're concave or convex. And the reason is that you can't predict. It all has to do with gravity pushing down on that infant as the infant's starting to stand and walk. And some of them will just cave in, and some of them will bow out. And you can't predict which will happen.
Because your answer was so quick on that last one, I'm going to sneak this one last question in that came in. And I don't know that you know the statistics on this, but how often is rachitic rosary mistaken for healing rib fractures at the costochondral junction?
In my experience, quite often that the radiologist no longer is thinking about infantile rickets. They just assumed that this was a disease that was conquered 100 years ago. We see probably on average about a dozen cases a year of overt vitamin D rickets at our hospital. And these are kids that are like 1-2 years of age that have classic bowed legs. So we think that it's more common than people think, and that the radiologist should be aware of this, because when you're looking at hypertrophy, it looks like these are healing fractures. But if it's at the costochondral junction, those are classic signs for the hypertrophy associated with vitamin D deficiency rickets.
We thank you so much, Dr. Holick, for taking the time out of your day to explain to us about your research projects and the different exciting things you have going on, and for taking this time to answer all of our questions. And I know that there's going to be more people that come up with questions, more people that are going to be interested in your research, interested in maybe coming to see you as a patient or wanting to have their family evaluated genetically. what is the best method for our viewers or other people that we know that would like to get in contact with you? What would you recommend?
Yeah, so I think that they can go to drholick.com, my website, so just drholick.com, and on there is a blog that is the one for the app, so dminor.info. So if you just go to my website, you'll see it. And so I often get questions, and I'm pretty good at responding. And then also those that wish to see me, then I don't obviously respond to everyone, but I just will email back to them. So that would be by far the best way to be in touch.
And we'll have a link on our website, fracturefamilies.org, to his website.
And does your website have your email address on it if someone wanted
Our
to send you an email?
His contact form.
Your contact
Yes.
form? Okay, perfect.
Well, thank you very much, Dr. Holick.
My pleasure.
Thank you
Thanks so
so
much.
much.